This is the Anthrobiology Podcast, hosted by me, Gabby LaPera. Every 2 weeks, I interview a biological anthropologist about what makes us, us. Good morning, everyone. Welcome to another episode of the Anthrobiology Podcast. Joining me today, I have Dr. Robin Wakefield of the Northeast College of Health Sciences. Congratulations on the addition of the S recently. Very exciting. And also I have Dr. Deborah Neidich of the University of Missouri Medical School.
Good morning.
Good morning.
Good morning. Hello. I'm really excited to have you guys here. I met you at the American Association for Biological Anthropologists conference. I met Dr. Wakefield at the conference. It was my first time going, and I had a great time. Everyone is so freakishly nice. I learned so many new things. I had a lot to drink, but that's kind of a personal problem, I guess. But in and amidst the conference, I met Dr. Wakefield when she was giving a poster presentation, and it was so interesting. I wanted to have y'all come on the show and talk about it. But I think before we get started, I think it would be great if listeners could learn a little bit more about each of you. So like maybe Dr. Wakefield, if you can talk about what kind of anthropology you specialize in, that would be wonderful.
Sure. I'll start. I graduated from the University of Pittsburgh in 2017 with my PhD, and I worked with Dr. Margaret Judd as my advisor. And my original research was on gender and mortality and activity patterns in Native American populations of the Ohio Valley. But now I've transitioned into looking more at how social inequalities and disability interact with social legal policies in the United States with specific respect to institutional care from cradle to grave. And our project that we're working on now is an analysis of medical records from one of the largest state mental institutions in the history of the United States, which is the Willard State Hospital in Ovid, New York. And I happened upon this when I was driving around my local area, and I happened upon the cemetery. And it is a large field full of unmarked graves where there are 5,776 patients from the history of the hospital buried there. And that really sparked my interest in that particular institution as I started to explore the impact of inequalities and structural violence on individuals and institutions.
This is like, especially in skeletal examinations of anthropology and disability, this is completely new for me, and it's very exciting to me that people are focusing on this and like actually talking about it. I think sometimes it's like people are really interested in like super sexy things, like looking at the occupational stress markers. Maybe I've been in anthropology too long. I don't actually know if that's a that's a sexy thing, but you know what I mean. Like this, it's exciting to be talking about people who frequently are overlooked by our society and understand like the roles that they played in societies in the past. But yeah, so sorry, Dr. Neidich, can you do a little introduction of yourself, please?
Yeah. So I got my PhD also at University of Pittsburgh, also studied under Dr. Margaret Judd. I graduated in 2022, and that's where I met Robin, or Dr. Wakefield. And my original hat was paleopathology and bioarchaeology. So looking at markers of health on individuals from the past. And my research mainly focused on climate change and how people adapted to climate change. So my research was in early medieval Bavaria and looking at sort of how climate disasters led to technological innovations that then led to better health outcomes amidst all of the myriad other things happening at that time. Then after graduation, I'm still kind of working on that. I'm working a little bit on research around anatomy education and also this project as well that Dr. Wakefield invited me into. And it's been really fascinating so far.
That is so cool. Listeners, if you're interested in like the biological anthropology of climate change, I also have an episode with Dr. Gwen Robin Shug who's great. She's so freaking nice. I don't know if you've met her.
Many times.
Yeah.
Yes.
She's incredible. Strong recommend on that episode. But that I think it's so deeply interesting because I think that people frequently see themselves like they see climate change as kind of like this big thing that happens outside of them, and they don't realize that it affects our bodies on like an individual level. Super cool. So I'm assuming you guys met in grad school.
Mm-hmm. We did, and one of the other researchers who was on this project who couldn't make it today is Dr. Jessica Walker. She was also in our PhD program with us, working with Dr. Judd as well, and she did research on biodistance and some other aspects of regional life in Jordan. And she works with me at Northeast College of Health Sciences. We both teach anatomy here. And another anatomist in our department who's also an anthropologist is Dr. Michael Zampano. He's also on the project with us. So just want to make sure we acknowledge everybody who's working on this with us, because it's not my project. It's not Dr. Neidich's project. It's the group's project. So
no, that's really good. This is a sign of like a very healthy group where everyone like wants to make sure everyone gets acknowledged.
Yes.
It's beautiful. So you it sounds like Dr. Wakefield, like you were driving around New York and you're like, you know what? I got to do this. How did you get everyone else on board?
Well, it's pretty easy because I work with Dr. Walker every day. And I mentioned this idea that I had, and Dr. Zampano also happens to be our department chair. We were sitting in our front office right before class, kind of thinking about research ideas. And as conversation organically flows, I mentioned this idea that I'd had been kicking around in the back of my head for a few months. And Dr. Walker decided that she would get on the State Archives website to see what archival material would be available. And she got the process started with finding out how to access certain things. And then I kind of took over from there in terms of being the liaison between the state offices and our project. But right now, just to kind of give you an idea of the state of the project, got some really, really, really exciting news yesterday. The psychiatric medical files are legally restricted in the state of New York, so only qualified researchers can access them. This is due to mental hygiene laws that are even more strict than your traditional data protection healthcare laws like HIPAA. So you have to go through a very lengthy IRB process in order to get access to these records. And we just got our IRB approval yesterday from New York State Office of Mental Health. So we could finally start accessing the actual patient files. But we have been able to access the publicly available data on patients at the Willard State Hospital and some other state hospitals in New York State.
I mean, holy crap. Congratulations. IRB reviews are no joke.
No, they're pretty serious. I mean, this one, we had to do a lot of training in terms of ethics and data protection before we were able to submit our application. And then we also had to wait because there is a team that has to review these projects. And there was just a couple of little suggestions for revision. That's something you can expect. If you're a graduate student and you haven't done an IRB before, it is something you can expect. Your first application may not be perfect. We were very lucky and they only had a couple of minor little suggestions that they wanted us to include. And they actually ended up being very good suggestions. For example, they suggested that we narrow down our ranges for time frame. So we were going to record deaths by decade, for example, but they said that would not maybe capture some of the data we wanted to look at. So they suggested narrowing down those gaps and provided some citations of other studies that I hadn't come across, which was really, really helpful and actually quite nice of whatever researcher put that comment in the IRB revision request. And that process took from submission to approval about 5 months.
Honestly, that's like blinding speed by an IRB committee.
It took a good 8 months to do all the trainings and make sure we had all the paperwork in line to get that IRB application in. But it's done. This was the big hurdle. And we got the news yesterday.
That's super exciting.
Yes.
Congratulations. I'm legitimately thrilled for you. I remember when I got IRB approval for my master's thesis, and I cried in a coffee shop in Lincoln, Nebraska.
Happy tears were shed yesterday. Yes.
No, so one thing I did want to note for listeners, because we haven't actually said this, I think, super explicitly, is that you are working with a population that is long gone. And I think that a lot of people don't realize that, like, even though you're dead, HIPAA still applies.
For 50 years. For 50 years after the date of death. But you can access and there's still some restrictions, some medical files for individuals who have passed away more than 50 years from the current date.
Yeah.
But it depends on, there's a lot of different state regulations. So it's very, very dependent on where you are.
And you know who loves regulations is the state of New York.
Indeed, they do.
I work in financial technology, which is, I was going to say that sounds a lot more exciting than it is, but maybe it sounds just as boring as it is. But perpetually, it's always California and New York, and weirdly Virginia sometimes, that are like, you know what? Extra laws. Which is, I think, good. I think overall good for the consumer. I know the company lawyer listens to this. Hi, Archit. Sorry, I'm pro making your job slightly harder, I guess. Anyway, so maybe we can start with, first, I think what I'm going to do is I'm going to read both of your poster titles. So to kind of like level set where we're at and what we're talking about. And then I'd love to talk a little bit about the history of both institutions and a little bit about like what the history of mental health institutions in the United States looked like before now, because the system we have now is actually not what it was for the vast majority of kind of American history. Okay, so poster titles. Life and Death at Old Main, an analysis of 19th century census records from the Utica State Hospital in Oneida County, New York. And the Willard State Hospital Project, 19th century demographic and mortality trends at a hospital for the quote unquote chronically mentally ill. Hi. Yes. Okay. So hopefully that gives people an idea of what we're talking about. We're kind of looking at like mid-ish 1800s to early-ish 1900s. So yeah, I guess, I don't know which one of you would like to kind of, I don't know if either of you have like a good summary of how mental health institutions in the United States have worked over time. But if either one of you have that, that would be excellent.
I can give you a quicker breakdown just to kind of summarize.
Yeah.
If you think about the history of the United States, we have several eras of history. We have the pre-industrial era, we have the industrial era, and then we have the more modern era. And in the pre-industrial era, really before increased urbanization and immigration, we had a very rural agrarian society. And at that time, the care of mentally ill individuals was really relegated to the local community or the family. People lived usually in, small towns where there may have been a larger extended family network. So there was a little bit more family support. But after increased urbanization and industrialization, when we have a shift from maybe local communities to maybe larger urban centers, there was an increased need for more formalized care because there were no longer these extended family connections, and also a lot of immigrants who didn't have any family here. So we had these large urban centers, and when you have an influx of individuals in a high population center, there are other things that come along with that, such as poverty, overcrowding, and other poor conditions that may lead to individuals ending up unhoused or in need of social services. And social services then were not what social services are now. In fact, then if you became impoverished and unable to care for yourself due to a lack of means, you were often relocated by law to a county poorhouse. And unfortunately, in cases like this, individuals who are mentally ill, there's often an intersection between mental illness, disability, and poverty. So oftentimes, individuals who are not able to work due to their mental illness or disability were relegated to life in the poorhouse. Now, the conditions in these poorhouses were very awful. Inadequate nutrition, unsanitary environments, overcrowding. There was a lot of infectious disease, really, really high impact labor practices, backbreaking labor. And so the conditions for the mentally ill in these county poorhouses was really, really quite awful. So there was a recognized, along state government lines, was a recognized among state officials need for more formalized care. It started with county poorhouses, but after that system took over, it was very clear that that was inadequate care for certain subsets of the population. So you will see a shift usually in the mid 1800s towards more specialized institutions of care, especially for children and infants, as well as people who were mentally ill. So the first hospitals in the United States that were dedicated to the treatment of the mentally ill are starting to become established in maybe the 1830s to the 1850s. And the Utica State Asylum was the first state-run asylum in New York State. It was one of the earliest state-run asylums in the United States. But the earlier hospitals were not designed to take care of people for the entire lifespan. They were really more focused on acute care, because the philosophy of treatment at the time was that people could be returned to a normal state if they worked really hard. We call this labor therapy. But after a few decades, it became very apparent that that system was not adequate, because people were being released from these hospitals and then ending back up in the county poorhouses, back in those terrible conditions. So states started to recognize the need for care, long-term care. So then state hospitals that were designed for permanent care for people who were deemed to be chronically mentally ill were established. And the Willard State Hospital was actually the first institution of that kind in the United States and became the largest one in the United States. And that became the model of care for individuals from the late 1800s all the way up through the 1950s and 1960s, even into the 1970s and 1980s. There's some work done on, which we can talk about a little later in the podcast when we get some more specifics on Willard. There's some really good work done by Darby Penny and Stephen Statsny, who are a couple of other researchers, that looked at some patient artifacts that were found in an attic at the Willard State Hospital. And they looked at patients who were admitted in the 1930s to the 1950s. And even up through the 1980s and early 1990s, there were people who had been relegated legally to life in the state hospital for their entire life.
Sorry, can I ask, is that the Suitcase Project?
It is the Suitcase Project. Yes.
So listeners, this is really cool. You can actually see this online. These researchers, some folks found a whole bunch of suitcases of patients who had been admitted to Willard, and just like, for whatever reason, their personal items were never collected. Like, potentially they died, and it's kind of unclear for some of them exactly what happened. But the researchers are like going through cataloging everything, and they're putting pictures of a lot of it up online, and it's amazing. It's like definitely worth spending an afternoon poking around. I've always loved like that kind of like imagining different people's lives. I think that's kind of why anthropology. Sorry, I didn't mean to interrupt, but listeners, you should totally check that out. I'll put a link in the show notes if you want to click through to see that. Sorry, is this also the hospital? Did Geraldo Rivera get involved with this?
It sounds very similar. The one you're thinking of is Willowbrook.
Oh, okay.
Which is on Staten Island. Willowbrook was actually the impetus for the deinstitutionalization movement. It started a little bit earlier during the administration of JFK in the United States. His sister was unfortunately lobotomized and ended up extremely disabled from that procedure. And he instituted the beginning of a shift away from permanent hospital care for the mentally ill to shift back into community care. But it really was that expose that was done by Geraldo Rivera in the early 1970s that really exposed some of the poor conditions that were prevalent in a lot of mental institutions in the mid 1900s, but they weren't all like that. I think that it's important to emphasize that. And the final kind of end of the institutional era of mental health care was the Reagan administration in the 1980s, where there were federal regulations to push to shut down state-run institutions and transition all of the patients back into community care. Unfortunately, the legacy of that movement to deinstitutionalize left a lot of people without care because the community care systems were not able to cope with the number of patients in need of care and the deep and vast array of care needs that they had. So this is kind of where we're left now. We've transitioned out into community care, where if you have a mental illness, you're often seeing someone in a clinic out in your community. And if you have severe mental illness where you may need some type of financial support or government support, you are usually relegated to government assistance, and that limits what access you have to certain providers. And if you are unhoused, it is very hard to obtain those types of benefits because you need a mailing address. So what happens is a lot of people who end up unhoused end up without care. And unfortunately, one of the only places people who are unhoused can get care is in the prison system. So you end up seeing a lot of recidivism among people who have been incarcerated due to the fact that that is the only place that they can get treatment.
Yeah. This is something that I've been thinking a lot about since 2012. For a very long time, Virginia did not have a system that tracked open beds in mental health facilities. And a friend of mine suffered the consequences of that, unfortunately. And it's the push towards community care. It's like great in theory, but it leaves so many gaps, like you pointed out. I guess thank you for giving a actually very comprehensive history of mental health institutions in the United States. First, I should acknowledge that. And I did want to put in my 2 cents on, if people who listen to the show ever go to Colonial Williamsburg in Virginia, there is a museum there. It's in the public hospital is what it's called. And it was the first public hospital in the United States. It was open in the 1700s, and they did house mentally ill colonists there because it's like 17 something. And their exhibits are incredible. Like Colonial Williamsburg actually does do an incredible job of historical interpretation and research. So if anyone's ever in Colonial Williamsburg, strong recommend. It's like a very sobering museum. But that's like way at the beginning. That's like 1700. And there was like a lot of kind of nothingness in between there in the 1800s. And we were like, you know what, maybe we should take social responsibility beyond just throwing these people in the poorhouse. All of that to say, so you have these 2 institutions. Do you want to talk about Utica State first? Would that make sense?
Yeah. Okay. I can start talking about Utica because it was the earlier institution, and it kind of leads into the establishment of Willard as a hospital. So Utica State Hospital was established in 1848, officially by New York State, to be the first institution that was funded and run by staff that was paid and nominated by state officials. And it was established as a care institution for people who were considered acutely mentally ill. The intent of treatment was to restore people back to a more quote unquote normal, because I hate that word normal mental state. And the thing about Utica was that there were a lot of different superintendents and people in charge of that institution over the first few decades of its establishment. So you had a lot of different treatment philosophies depending on who was in charge. The earliest, I cannot remember his name off the top of my head, but the earliest superintendent was very much into the idea of utilizing labor therapy, but also providing some other type of enrichment. So he would bring in things like music and dancing and lectures and book readings and some type of social enrichment to the patients' lives. But there were subsequent directors that were not as, say, liberal minded in their treatment philosophy, and they were a little bit more punitive in their approach to treatment. So the main philosophy of treatment throughout the earliest decades of the Utica asylum, and it was called an asylum when it was first opened, was labor therapy as the primary means of therapy. Labor therapy was essentially, we will work you very hard, and by working, your brain will be restored to a state of morality, because mental illness was considered a moral disease. And they thought that hard work, being this very 19th century ideal, everyone, is supposed to work very hard, and that is the ideal that we want to, espouse. So that was the mode of treatment. And labor therapy involved many different types of industries, and it was very divided by patient sex. So patients who were male, or biologically male by 19th century standards, were mainly forced to work on the farms. The farmland and farm products would support the institution. So they would provide all of the food. And if they sold anything, the money from those products would go back into the institution. They also did things like carpentry, building. And then women were very frequently relegated to domestic industries, cleaning, sewing, weaving, textile industries, and those products would be sold. But the issue with labor therapy at Utica was that it was not optional. Individuals who were patients at Utica were forced to do labor therapy. And if you refused to comply, you were often put on a locked ward or somehow otherwise punished for that. The other methods of treatment were more punitive measures, like the use of chemical and physical restraints. Some of the earlier forms of physical restraint were something called the Utica crib. It was actually invented at the Utica State Hospital. It was basically a cage that would surround a bed that would keep the patient locked in a recumbent position. And the camisole, which was the earlier form of the straitjacket. These were physical restraints. Chemical restraints, such as chloral hydrate, were also used once that was invented.
Yeah.
Towards the middle part of the 19th century. So the issue with Utica is that patients would be there maybe for a few months, maybe up to a couple of years, and then they would be released out. And they may not have actually recovered or had any improvement in their condition. And then they were sent either back to their families or they were relegated back into the county poorhouses. So that's a little bit about the Utica State Hospital.
And then the Willard State Hospital. I guess actually, you know what? No, let's talk a little bit about Utica and like what y'all found there, because you were looking at the census records. So like, what were you hoping to find? What were you looking for when you were looking at the census records?
So the census records there's two types of censuses. Censuses, is that a word? Censi.
I don't know.
There are basically two sets of census records that you can look at. There's the population census, which the federal government released every 10 years. That will give you a rundown of the living population structure of the United States. So all of those records will list all of the patients who are currently alive in an institution for that census year. But then there's something that's really important, but only available up until 1880, is the federal mortality census, where they tabulated every death, every census year. And not only did they tabulate who died, but they tabulated the cause of death. So we can get some epidemiological information and some demographic information about living populations as well as mortality in the 19th century from those records. And people in institutions the institutional deaths were delineated on those censuses. So you can actually pinpoint if someone was in an institution on the mortality census, because there is usually a little column that says family number. And if it doesn't say outright on that mortality census record what institution they were in, their family number will correspond to an institution in the living population census. So those records are really important because they're publicly available. You can access them on ancestry.com or Family Search. So those are really, really good sources of information, but they have their own sets of limitations. So what we were hoping to gain from that is to find sort of general demographic structures of the living patient population, as well as general trends in mortality for each institution that we were studying.
Perfect. Dr. Neidich, can you talk a little bit about the results that you found at Utica?
So part of this research was, again, to compare general population trends of cause of death and those observed at the hospital. And we saw sort of differences in at least listed cause of death associated with each of these different populations. So the general categories for cause of death that we assessed, kind of based on the limitations of the data at hand, were things like mental illness, because that could be listed as cause of death on a mortality census, suicide, apoplexy or stroke, different neurological conditions, different acute illnesses, infections, marasmus, which is malnutrition, and then congenital conditions. And when we looked at sort of population differences between Utica and the general population year by year within these decades-long kind of chunks, we did notice that there was sort of a difference in frequency for things like acute illness, especially in 1850, differences in people dying of infectious disease, and people dying of apoplexy or stroke. So,
was it higher in the institution or?
yeah. So you have kind of these higher rates of these stress related causes of death, at least those that were recognized by whoever filled out the paperwork.
Oh, that's a good point. I was going to ask, because they're historical records and they're also operating with the medical knowledge that they had at the time, like how much can you, how do you navigate trusting them? How far can you trust them? Do you know what I mean?
Yeah. So when we are working with these older medical records, I do think that the people writing these records do take their job seriously. That said, based on medical knowledge, limits of time, usually only a single cause of death is listed. Very rarely do we get more information. So, like comorbidities, every once in a while you get lucky and you get someone who wrote really good notes. But for the most part, it's just kind of a single little box that's ticked or filled in that says, this person had consumption, this person had typhoid. And, that's all we really have to go on. On top of that, things can be a little bit nebulous in our understanding of what the actual diagnosis is or how we would medically diagnose something now as opposed to a description of something in the past, because you can get very vague, entries like inflammation.
Oh, good.
Inflammation of what? What caused the inflammation? Like just some very general type things. So it depends on the diagnosis and it depends on sort of what knowledge was at the time. But I would say that, they are decently trustworthy if you are working in the same frame of reference,
right,
as the person who is writing all of this down.
Yeah, that totally makes sense. Side note, a friend of mine texted me and he said that his 26-year-old colleague didn't know what cholera was. And he was bemoaning the fall of Oregon Trail. He was like, this is the saw the video game.
Yes, there's a lot of Oregon Trail era diseases on these records,
Yeah.
and I would say just kind of just to add what Dr. Neidich was saying is for a lot of the infectious diseases, we have quite good data from these records because very specific symptom sets were recognized even in the 1850s and 1860s. But when it came to things like neurological conditions, because neurology in the brain was very poorly understood by the 19th century physician, we would get diagnoses like paralysis
or
a lot,
Fits.
or fits. That doesn't tell you very much because many things can cause paralysis, such as strokes can cause paralysis, but certain neurodegenerative diseases can also cause paralysis. Trauma can cause paralysis. Many things can cause seizures. Infectious diseases can cause seizures. Traumatic injuries can cause seizures.
Being
Epilepsy
poisoned.
can cause seizures.
Yeah.
So a lot of these diagnoses are kind of these wastebasket categories that just describe a symptom rather than a disease process. So you have to be a little bit more careful when you're using these types of records. And you'll see when we work with our classification of conditions, very often we won't give a more specific diagnosis to a category. So, for example, when we say apoplexy or stroke, apoplexy may have been a stroke, but it wasn't always a stroke because it really just described general paralysis or facial paralysis. Very likely is a stroke and usually is associated with the age range where you'd expect strokes. However, it's not always very clear whether or not that diagnosis was accurate based on the set of symptoms described in 19th century medical literature. Oftentimes, I will put paralysis in as its own category, for example, because you can't really pinpoint a specific cause there. But it is an important data point because people may have conceptualized of people who had physical disabilities like paralysis in a different way than they would conceptualize somebody who died of more of an acute infectious disease. So these are really still important units of analysis, even though they don't really jive with our modern medical minds. But those are some of the limitations. And maybe Dr. Neidich, maybe you could talk a little bit about how difficult it is sometimes to interpret some of these records.
I mean, yeah, in general, some of that record interpretation is already kind of iffy because first off, you have to be good at reading other people's handwriting because they are all handwritten. So being able to read someone's handwriting, being able to read someone's shorthand, all kind of a bit of an issue to like slog through on top of people using names for things that we don't use anymore. So that's always like a little bit of a trick trying to dig through records. And sometimes I've found myself going backwards through records. So, some people are very good at Facebook stalking. I've become good at history stalking. So trying to find their obituary and see if that lists how they died because I can't read this guy's handwriting, or try to find, I once got very lucky and found a guy who had a Wikipedia page. So that was quite enlightening because then I was kind of able to get a little bit more data on that individual because I couldn't quite read these records. On top of that, they're scanned. So we have old-timey handwritten records that are scanned, and sometimes the scans aren't great. Sometimes there's bleed from, the previous page, so they become hard to read that way. Sometimes they're just kind of blurry. So working with old records is, a challenge and an exercise in and of itself. And I definitely find myself at the end of a long day copying records. I feel very tired.
Yeah, totally.
I've worked out and it's like, no, I've been sitting at my desk all day.
So totally. I came up, I guess, in like Williamsburg doing colonial bioarchaeology. So like that historical bioarchaeology thing, everything was kind of like hand in hand. Everyone had to do historical research and everyone had to do like biological anthropology at the same time. And it is why is their handwriting so bad sometimes? It's crazy. I'm like, Sorry.
No, it's beautiful, but it is hard to read.
So hard to read. Looking at the governor's mansion in Williamsburg, I had all of their purchasing records for food. It was terrible. Someone has since digitized it and like put it in plain text. And I was like, why didn't that exist when I was in college? but bless that person, I guess. I do want to like be careful of our time because we are going to run out of time soon. Do you want to talk about Willard real quick?
We should talk about Willard because that's the big thing.
Let's talk about Willard.
But the Willard State Hospital was established because there was a need for care for people who could not care for themselves long term. After being released from some of these other institutions like the Utica State Hospital, we saw a lot of influx of individuals back into county pauper facilities, so poorhouses, almshouses. And again, the state of care for the mentally ill was very bad in those places. And New York State recognized that. So it was actually the Willard Act that was enacted, I believe, let me look up the year here. I have it right in front of me. In 1864, Dr. Sylvester Willard, he was a medical doctor. He wrote a report of the state of care of the mentally ill in these county institutions. And it was basically the Geraldo Rivera of his day. It was an expose essentially on the poor state of affairs for people who were mentally ill. And it was the Willard Act that was passed several years later that established the opening of an institution whose sole purpose was to care for those deemed chronically mentally ill for their entire lifespan. And the treatment goals of that institution were very different than the treatment goals of Utica. Remember, Utica was focused on labor therapy with a very short-term focus on treatment, whereas Willard was focused on treating individuals until they passed away. It was really, really more lifetime care. But the method of treatment was really just very simple, but relatively radical for its day, was to provide a clean, sanitary environment, adequate nutrition, and a calm setting. Because one thing about Willard is that it is out in a very rural area. Now, this was done for two purposes. One, it was a calm environment, but two, it was out of the way.
Mm-hmm.
So these people were still stigmatized. There was a huge stigma against mental illness in the 19th century. So this place was out of the way, out in the country, where people would be kind of out of sight, out of mind from the general population.
It's nice to know that NIMBYs have always existed.
Yes.
I guess.
There was labor therapy at Willard.
Mm-hmm.
However, the participation in that therapy was more voluntary. So individuals who were not able to perform physical manual labor were still cared for and were not punished for not being able to do so. And people who maybe would be more reluctant to participate in those types of activities were still cared for. And what was interesting about the labor therapy at Willard is that there was a lot more freedom in terms of what individuals could be doing. There was a dairy farm, it was crop farming, but there was also carpentry and cottage industries like basket weaving and sewing. But some patients were artisans and had unique skill sets. So, for example, there was one man who had a little shop where he made clocks or fixed clocks. So people could maybe set up their own little businesses within some of these cottage industries within the hospital. And this hospital was acres upon acres of farmland. And it was its own kind of self-contained town. It had its own railway station. It had its own post office. And it was its own contained little town really up until the 1950s and 1960s. At that era, the hospital was actually kind of more open to the public. They would have public movie nights there. There was an ice skating rink and a bowling alley that were staffed by the patients. So it was very much an integral part of the surrounding communities, even though it was kind of separated from maybe larger urban centers, but it was very important to the local area. So the big differences between the two institutions are conditions and mode of treatment. So just to kind of think about what Dr. Neidich was saying, we saw a huge amount of acute illnesses in 1850 in Utica. One of the biggest ones was dysentery, which tells you that there's unsanitary water or food in that institution. We're not seeing dysentery in the same rates out in the general community. It's much higher in the hospital in Utica. And in 1880 in Utica, we saw a huge incidence of meningitis, which was also not present out in the general community of Utica. So it was like 25% of the deaths at Utica in 1880 were from meningitis. But in the general community, general population of Utica was only 2%.
Wow.
So there's a big difference. Meningitis is a kind of a unique disease in that it spreads very quickly in communal settings, in institutional environments. So it was very much a factor of the institution itself and a very unique epidemiological consequence of having that institution. But what we don't see is we don't see high rates of meningitis and dysentery at Willard. So we can see that maybe sanitation and disinfection was a little bit better at Willard. And generally, if we're looking at sort of general demographics between the two institutions, the average age of the patient at Willard was maybe a little bit older, but the age at death was significantly older at Willard than at Utica, which indicates that patients were surviving longer. There are also lower ratios of deaths to living population if you compare the number of deaths to the number of living patients in the census. For example, there were only 7 deaths in 1870 and 250 living patients. But at Utica, let me give you those numbers. There were 70 deaths and 629 patients.
Damn.
So there was a much higher ratio of death to living population at Utica, which gives you an indication that maybe conditions were not as good at Utica.
And what about Willard in comparison to the general population?
Okay, so if we wanted to compare the kind of age at death of patients at Willard to maybe some major urban centers of the 19th century, the mean age at death for 1870 at Willard, when there were 250 patients, was 55.7. Whereas if we would compare that with Rochester, which is a large urban center in a nearby county in Monroe County, New York, the average age at death for adults was 48.2. So people in the institution were living longer than people in major urban centers. And Onondaga County, which is Syracuse, were living on average 49.1 years. By 1880, things had equalized a little bit. The patient population of Willard had really, really swelled by 1880. They were over 1,500 patients, which was very crowded. So the average age of death kind of goes down a little bit by 1880. We're looking at about 49.6 years as average age of death. Whereas in Rochester and Onondaga, we're looking at approximately 50 years. So they're very similar. But if we look at Utica, Utica actually is much lower than the general population in terms of age at death. So Utica in 1870, the average age at death was 46.1 years. Whereas again, in those urban centers, we're looking at 48 or 49, so a couple of years younger. But by 1880, it's much worse. In 1880, the average age of death is 43. But out in the general community in these larger urban centers, we're looking at 50. So there's a 7-year age difference. And then we haven't really looked at statistical comparisons yet because we're waiting on a larger swath of data for that. But that is quite a large difference. There's a marked difference.
Yeah.
So we're seeing that the patients at Willard were a little bit more comparable to the general population than the patients at Utica in terms of their causes of death and their age of death.
And to just kind of jump on to that too, this is also with the understanding that the general population is including more children, where you don't have those youngest age cohorts for the most part at these institutions.
That's a good point.
We have a lot of, unfortunately, death of, infants, little kids.
Yeah, and the general population.
Your general population.
Right.
which aren't going to be represented in these institutions.
Right. And so that in theory would bring the average age of death down for the general population. So for it to still be lower in the institutions than in the general population is actually kind of crazy.
Yes, it is.
Really significant.
Especially when you're looking at Utica. And if you look at cause of death, the Willard kind of death profile, even there's a little bit of a skew, a little bit of a difference between the Willard cause of death profile and that of the general population, because it was a specialized institution for people with mental illnesses. We see a little bit more of mental illness classification for cause of death or neurological conditions, things that you would expect to manifest in a psychiatric diagnosis during that time. But if you look at the infectious disease profile, it's very similar to the general population in that most of the infectious disease deaths among adults were tuberculosis. Tuberculosis is going to be the most prevalent infectious disease in pretty much most communities, especially urban communities in the 19th century.
So very different from Utica.
Very different from Utica.
I'm so sorry that we have to wrap this up because I have to go to a meeting. But I did want to ask you both, if people want to learn more about the kind of work you do, is there a place that they can go to get started? You can also recommend, it doesn't have to be like your work in particular, but like it can be like an intro to bioarchaeology textbook or something like that, if that's helpful.
Well, definitely that Willard website.
Oh
yes. There's a website called Inmates of Willard. There was a local historian who put together a lot of historical documents kind of in one place and has been doing a lot of advocacy for getting grave markers on the graves of the people in a cemetery there. And she did a genealogy project and she wrote a book on it. So it's inmatesofwillard.com, I believe. And then there's another book that was written on Willard. It was the one that was on the suitcase project. Mm-hmm. It was called The Lives They Left Behind. And that's by Darby Penny and Peter Stastny.
Perfect.
It's a more recent book. There's a lot of really good information about Willard and institutional care in general in that book. And it's a really, really good, accessible book for maybe a more non-academic audience. So it's not really a thick, research heavy and accessible read. And it really does get the message across of really what life in these institutions was like and really puts the human face back on the patient, which I really, really appreciated. It was one of the best books I've ever read. And it really, really it was kind of emotionally devastating, but also very important. It made me really think very deeply about the reasons why we need to do this project.
That's a glowing review.
Yes.
Second question, what are y'all reading for work right now?
For work? I'm currently reading articles on variations of the dorsal scapular artery. Because I'm
fun.
Yeah, I'm teaching. I teach anatomy, so one of the things we need to teach is common variations on blood supply and different arrangements that are recognized. Variations are recognized in anatomical features in the body. And I was just reading some articles about the frequency of variations on that artery because they are somewhat more common than other variations. That's what I'm currently reading for work.
Cool.
I'm mostly doing article reading too, but my articles are about using role playing in anatomy education and education in general.
Oh,
so
neat.
That's a lot more fun.
Yeah,
that's a lot more fun than articles about the dorsal scapular artery. No shade to the dorsal scapular artery, though. It's very important.
Maybe role play as a dorsal scapular artery. Where are you sending blood to? Where are you getting it from?
Oh my goodness. This makes this question appropriate. What are you reading for or consuming for fun right now?
This is the book I'm currently reading, Mexican Gothic.
Oh, do you like it?
It has nothing to do with anything. It's been really enjoyable so far.
That's fine. It's for fun. It doesn't have to have anything to do with anything.
Yeah, it's for fun.
Yeah.
I did start it like several months ago, so I'm really bad at reading for fun, but
that's fine. I've been reading Careless People, the Facebook one, or Meta, I guess it's called now, for like 3 weeks because I have to keep putting it down because I keep getting like physically ill every time I read a chapter. I'm like, this is horrible. So I get it. What about you, Dr. Wakefield?
I am currently reading the second book in the Thursday Night Murder Club series. It is a series of books about octogenarian residents in a retirement community in England, and they solve crimes. And it is fascinating and hilarious. And I like to listen to those on audiobook while I paint my number.
My friend Jen keeps recommending that to me. It's on my to read list.
It's highly recommended, and they are hilarious.
There's also a role-playing game where you can play as an octogenarian solving murders. It's called Brindlewood Bay. Fun fact.
Oh my gosh.
That's what I spend most of my time doing.
I would love to party with y'all. Seriously, I hope that didn't come off as sarcastic, because that sounds like a ton of fun to me. I do have to run, but thank you both so much for your time. I'd love to have you back on when you have more research on this. I think the listeners would be interested.
We would love to be back on.
Have a good day.
Yeah. Thank you for having us.
Thank you.
Bye.
Bye.
Thanks for joining me for this episode of the Anthrobiology Podcast. If you have questions or comments, you can reach me at gabby.lapera@anthrobiology.com. That's spelled GABY.LAPERA@anthrobiology.com. This show is produced by me. Music courtesy of Chad Crouch, aka Poddington Bear at Sound of Picture.